Thank you, Dr. Gallus. Hello, everybody, and thank you to the organizing committee for having me, and I'm delighted to present and honored and in front of such an audience. So, and it was kind of strange to prepare a talk on, it was state of the art, but it was controversies. So I'm happy there is no question at the end so that I can give my own opinion and you just have to accept or disagree. So obviously it remains a challenge in daily clinical practice. And numbers that we sometimes forget is that we used to say the incidence of VTE is 1 to 2 per 1,000 every year. But when we test a patient for suspected VTE, we only confirm 1 in 5 or 1 in 6, which means that almost 1% of the population is tested every year for a query deep vein thrombosis or pulmonary embolism. And as you all know, our clinical signs and symptoms like diagnostic accuracy, they are often shared with many other life-threatening conditions. And that being said, we need to avoid misdiagnosis because of the risk of fatal recurrent PE if we miss a case of PE and the unacceptable risk of bleeding if we treat someone for no reason. The other challenge is that over the years, we have seen a decrease in the proportion of confirmed cases. So at the time of the PIOPET study 20 years ago, 33% of patients with suspected PE had a PE at the end of the investigation, while in most recent study, only 10 to 15% of patients, usually we are able to confirm the disease. We've made major progress for sure, and mostly during the 2 previous decades. So if we look at the story of the VQ scan, which was the first attempt to replace our gold standard test, and I will take the example of PE, say the PIOPET was an accuracy study in the 1990s, and very soon after we had an outcome study confirming that it was safe to rule out PE in patients with a negative VQ scan. The dimer test, the first description, and I don't want to, I'm sure you might find some papers older than that, and so I won't give any names or but you will, just to get you a global idea on the topic. So just to say that the first paper I've seen, at least, were at the end of the 80s describing D-dimer as a potential tool to rule out VTE. Accuracy study very soon after that, and the first outcome studies, again showing that it was safe to rule out VTE on the basis of negative D-dimer, were published in the mid-90s. CT scan, same kind of story. In the 80s, you would find some description of patients undergoing CT scan, and they would see a clot there. But truly, the first use of CT to detect pulmonary embolism was proposed in the very early 90s. And the accuracy study against pulmonary angiography at the end of that decade, and the outcome study very soon after that. And you remember that we were first using some single detector CT scan, which we would call spiral CT or helical CT, but very soon after, the arising of the multi-detector technology and the validation of this technique arrived soon after with the Christopher study in 2006 and CTP4 in 2008. Same kind of evolution for clinical probability. In the PIOPET study, for example, it was the first time we really used clinical probability for PE suspicion. And in that study, it was a Gestalt estimate, the empirical estimate that was used. The first clinical decision rule was published in 1997, and its use validated soon after. What is impressive is that when you look at, again, the PIOPET study, it was possible to do a pulmonary angiography to 100% of the patients included in that study, and that was 25 years ago. When you look at the data, for example, a study by Arnaud Perrier in 1999, he was doing pulmonary angiography in case of inconclusive diagnostic strategy, and that happened in 11% of patients. A few years after, 1%. And since 2006, you haven't seen any pulmonary angiography in any study on diagnostic algorithm. So basically, in 15 years, we were able to get rid of that invasive, expensive test, and now we are completely using non-invasive strategies. Yet, we don't have one single, inexpensive, non-invasive, accurate test that would allow us to say us for sure in front of all the patients with suspected VTE whether or not they have the disease. What we do have are tests that might, reinforce our conviction that the patient has a disease or reduce the probability that he's affected. And in fact, what we are trying to do is to reach enough certainty, enough likelihood that the patient has a PE that for sure he will benefit from anticoagulant therapy more than he will have the risk of bleeding. And on the opposite, we don't want to make sure there is no clot. What we want to make sure is that the chance of having a clot is so low that that patient would get more risk of bleeding from anticoagulant therapy that he would get benefit. And usually we're happy to rule in the diagnosis when the chances of the patient actually having a PE is above 80 to 85%, happy to rule it out below 3%. So in fact, and that's something we sometimes forget, these diagnostic algorithms are as much therapeutic as they are diagnostic strategies, because they help us decide in who needs treatment and who doesn't. They don't say for sure whether the patient has a clot or not. And that's particularly relevant today with, we've heard at the SSC the other day, the debate about, distal DVT and subsegmental pulmonary embolism. And again, I think that's something we need to keep in mind. We're not trying to make sure there is absolutely no small clot anywhere. We are trying to make sure the patient needs or doesn't need anticoagulant therapy. So we're using sequential diagnostic tests, all the strategies being based on the pretest probability assessment, and these strategies are validating a management outcome study in which we include consecutive patients with a suspected disease. We apply the algorithm. The patient with a negative workup are left untreated and followed over time to assess for the risk of thromboembolism during the 3 following months. So basically, the current strategy is to first do pretest probability assessment. If the pretest is low, intermediate, or unlikely, then you do a D-dimer. If it's a sensitive D-dimer and if it's negative, then you're happy to rule out VTE. If it's positive or if the pretest is high, then you do imaging tests, and that would be ultrasound for DVT, CT or VQ scan for PE. On that, obviously, many areas of controversies, ongoing debates, things that are not completely, but for sure, for the last 10 years, we've been rather refining or better defining these strategies rather than having big advances that we've seen over the previous decades. So for pretest probability, should we use Gestalt, clinical decision rule better, which one to use, should we use a 2-level or 3-level CDR, same kind of discussion for the D-dimer, which one should we pick up, at which threshold, for imaging, for the PE, it's still the debate on CT versus VQ. If you use VQ, should you use a planar VQ or a SPECT VQ? For DVT, we've heard debate also on whole leg versus serial proximal ultrasound, imaging one or the 2 legs. And most globally, whether that strategy, whether that one size fits all, or whether we should tailor the strategy in subgroup of patients, such as pregnant women or women with patient with previous VTE, elderly patient, and so on. So obviously, each of these controversies would deserve a 30-minute debate, right? So I will just choose some of them and quickly comment on the current ideas on these. So about the pretest, very importantly, it's truly the first step of all the validated diagnostic algorithm. It helps selecting the patients that are eligible for D-dimer testing. For DVT suspicion, it helps selecting the patients that require serial testing, and it's mandatory to enable interpretation of the VQ scan and the CT scan results, even if I've seen that an oral communication tomorrow will help with interpretation of the CT scan according to clinical probability. So we know Gestalt works, and it has been compared in many studies, and if you deal with experts, physicians, such as all you in the audience, for sure we know you don't really need a score. You're able to assess the clinical probability of a patient. But for sure, the clinical decision rule provides something that is more reliable, reproducible, and which is also less dependent on physicians' expertise. And I think that's important when, the pathway of a patient through the system of care, it's important that, the clinical priority would be the same for the emergency doctors that receive the patient and then for the attending, so that we are sure it remains consistent through the diagnostic strategy. Which rule to use? So for DVT, the Wells score is the most validated. For PE, Wells Geneva score are the most validated as well. I won't enter into the debate of which one you want to pick up. They've been shown to have similar performances. And I think beyond that, what's really important is to make sure that you implement in your center a diagnostic strategy that does include a clinical decision rule. And that's a study that I like a lot from Pierre-Marie Roy, He did a study of 1,500 patients coming to 117 emergency rooms and looked at whether these patients received appropriate management for PE or not. And in fact, up to close to 50% of the patients did not complete a diagnostic algorithm for PE. And when you look at the consequences of that, the risk of developing a VTE and including the risk of sudden death during the 3 months following that initial suspicion was much higher than in patients who did receive appropriate management. And one of the main risk factors for not having appropriate management was not having in the emergency room a written diagnostic algorithm, including a clinical decision rule. Should we use 2 or 3 levels? So that's something interesting as well. You know that's, for example, the well score for PE. You can use it in 2 categories, unlikely or likely, with 4 points being the threshold, or you can keep the 3-level system. Which one to pick up? Again, I think it depends on which kind of assay you have. So if you're using a less sensitive D-dimer assay, for example, you should restrict the use of the D-dimer to patients with a low clinical priority. If you are using a more sensitive, most studies now have validated the use of the D-dimer in all patients with unlikely PE, but it's likely that with the highly sensitive assays that we have now, we could likely extend that even to the patient with intermediate probability so that you, again, gain more yield for the D-dimer in ruling out pulmonary embolism. We've been working a lot as well with trying to have simplified version. We heard that for the PESI score, for example, it's hard to memorize. You have many items, all with a different number of points. So years ago, we said, oh, we should simplify that and give 1 point to each of the variable in the rule. So, for example, Dr. Clark did that for the Geneva score. And that was aimed at being more user-friendly, easier to memorize, and so on. And I will be presenting on Tuesday a poster on the validation of the simplified Geneva score. But for sure, I'm not sure it's really relevant now. I don't know what you're feeling on that, but obviously we all have these iPhones and there's medical apps and all the scores are there, and I'm not sure I even remember the Geneva score myself, and you know, just because it's there on my phone, right? So why would I? So same debate for the D-dimer test. So again, strongly validated test. It rules out DVT or PE in combination with a clinical decision rule in a huge proportion of patients, more than 30% in patients with suspected PE, close to 50% in patients with suspected DVT. But I'm sure you have heard so many times, oh, I don't like it, I don't use it, it's always positive. Why would I? I just get a CT scan and that's easier. So for sure, it's true, right? It's not a specific test. It's often positive, but the misconception is that obviously you need to prescribe it or you need to get a D-dimer test only when you actually suspect a disease, which means that you're ready to go up to imaging if needed, right? So worst case scenario, it comes positive and you have to do the imaging, but otherwise you would have had to do it anyway. So can we improve that though? Because we know it's increased in many subgroups of patients with previous VTE, cancer patients, elderly patients, and so on. And we would like to increase the yield of this non-invasive testing for D-dimer. So I picked up the example of the elderly patient, and you've heard already about the ADJUST PE study. So it was a very nice collaborative effort between centers in Geneva, France, and the Netherlands as well, where so René Dumas from the Netherlands derived the score and came up with the fact that after 50 years of age, the optimal D-dimer cutoff would be the age of the patient multiplied by 10. So if you are 72 years old, your cutoff is 720. If you're 83-year-old, your cutoff is 830, and so on. And we were able to validate that in a prospective outcome study where all the patients with suspected PE had the pretest probability assessment, the D-dimer, and all the patients with the D-dimer below their age multiplied by 10 were left untreated without any imaging test. And we found that we were able to significantly increase the proportion of patients with a negative D-dimer test, and particularly in elderly patients. So after 75 years of age, only 6% of patients had a D-dimer below 500, but when you were using the age-adjusted cutoffs, that proportion would increase up to 30%. So truly increasing a lot the yield of the test in these patients. Can we use it to rule out the DVT? I don't know yet. So we've done, René Dumas again, some retrospective analysis of previous diagnostic databases showing similar results, similar safety, and increased yield of the D-dimer test. For now, we don't have a prospective study formally validating that. I've seen that on Tuesdays there will be 2 posters from teams in the UK. I don't know exactly what the kind of study it is, but reporting on the value of the age-adjusted to rule out DVT, so we'll be interested to see that for sure. And we're just starting a very similar study to the Adjust PE, but using the D-dimer to age-adjusted to rule out DVT. Other approaches are ongoing to improve the yield of the D-dimer test. We've heard Dr. Kiran the other day about the 4D study and the PJET study trying to use a selective D-dimer threshold, not based on patient's age, but based on his pretest probability. Likely, if the pretest probability is low, we can safely rule out a DVT or a PE as long as the D-dimer is not above 1,000, but that remains yet to be prospectively validated. And similar approaches are ongoing in patients with cancer, pregnant women. We've seen some papers showing the median results of the D-dimers throughout the pregnancy, and perhaps we could rule out a VTE by increasing the threshold as well, but that's too early for sure. And what happened is that likely at the end, or years from now, we'll have not one single threshold, 500 microgram per liter per everybody, but an individualized D-dimer threshold that will take into account all the comorbidities, risk factors, and so on. Imaging for DVT, some controversies there as well. The main one being, should we image only the proximal veins, or should we do a whole leg compression ultrasound? So initially, years ago, there were some concerns about the accuracy of the ultrasound at the level of the calf. So that's why they said, well, if the ultrasound is not well able to detect DVT in the calves, then let's just image the proximal veins, but repeat the image 1 week later to ensure such a small clot wouldn't have extended in the meantime into the proximal venous system. And that approach was perfectly demonstrated. Many outcome studies at the end of the 90s, early 2000s, showing that it's perfectly safe to rule out a DVT based on that. The use of the single whole leg ultrasound appeared a little bit later, first study in 2003 and several studies up to 2010, showing similar safety in terms of ruling out DVT. 2 trials have been comparing the 2 techniques, the 2 approaches, and as you can see, indeed, there is no difference in terms of safety. So when you do whole leg, it's easier because the patient doesn't have to come back, so it's perhaps more convenient. But the issue with that is that we are increasing the proportion of patients that we treat for a positive DVT. So in the study by Bernardi, you had the proportion of confirmed DVT was 26 when you were using whole leg as compared with 22. And as you can see, it's because you were detecting a lot of distal DVTs that obviously the proximal ultrasound did not. And same results in the study by Gibson, with a higher proportion of confirmed DVT as well, and a huge proportion of the DVTs diagnosed in the whole leg arm being distal DVT only, while the safety of ruling out on the basis of a serial proximal was just the same. So, and that's a slide from Marc Aghini, summarizing, advantages and disadvantages of the 2 approaches. So for sure the 2 are safe, and the whole leg is a standalone test, might help getting alternative diagnoses, tear muscle or Baker cyst, but is longer to perform, more difficult as well, and has a significant risk of over-treatment. And again, what we want to do is not knowing who has a clot or who has not, we want to know who needs treatment. And what I often hear is, in Europe is, or in France at least, serial proximal, you can't do it because you have to make everybody comes back 1 week later, and that's not convenient. So that was true initially. That was the first approach. But when you look at that study by Phil Wells already 10 years ago, what he did was to select the patients that actually require a serial testing. So if the D-dimer is negative, obviously rule it out. If the pretest is unlikely and you have a positive D-dimer, then you do a proximal ultrasound. And if it's negative, you rule DVT out because the clinical probability is low. That patient doesn't come back for a serial ultrasound. If the well score is likely, you get your proximal ultrasound, you don't do the D-dimer. If it's positive, you treat. If it's negative, again, you do a D-dimer there, not to rule out DVT, but to select who needs a serial ultrasound. And if the D-dimer is negative, the patient doesn't come back at the second week either. So which means that only 15% of the patient in that study actually had to come back a second time. And doing that resulted in a very safe diagnostic exclusion rate of DVT. One leg or both, that's another controversy. A patient comes in with a left leg symptom. Do you need to image the right leg as well? And there is variation in practice across centers as well. So we recently did a retrospective analysis of 2,800 patient charts that came in with suspected DVT, and we looked at how many times imaging the other leg would find something significant that we would be sad about having missed. And we found that some patients coming in with left leg symptoms would have a right leg DVT as well, okay, 1% of them, and these would be mostly cancer patients. But you found a clot in the left leg as well, right? So it won't change your management in terms of anticoagulant therapy. And most importantly, is the risk of finding a proximal DVT, not in the leg with the symptoms, but in the other one was really, really low. Okay, so basically, and likely, the chance of that being a false positive being likely significant as well. Imaging for PE. So the main debate, and you might say, oh no, not again, CT versus VQ, forget about the VQ Le Gal. Okay, so, and I don't think we should do that. I think VQ has still a role for sure. How many people in the room routinely use VQ except in patients with contraindication to CT scan? So raise your hands, who's the one who, okay, not many hands, okay. So I will try to change that. So obviously you know that very well, you've seen that slide so many times saying, the VQ scan, you can't get it, it's often inconclusive, the strategies are much more complex, even if we know that it gives less radiation and it has no contraindication, so that's when it's mostly used now, right? I mean, patients with nephropathy or allergies, then we get a VQ scan. And, we also, something to mention is, we used to say CTPA is good because we find alternative diagnosis. I was very interested by a recent study from the Netherlands showing that, in fact, it's perhaps true, but how many times that alternative diagnosis actually alter patient management is really unclear. So that's something that deserves more attention as well. Truly, the main reason why I still fight for VQ scan is the overdiagnosis with CT, right? When I've shown you initially the slide where, we're happy because we got rid of the pulmonary angiography and we were happy about multi-detector CT, but during all these years, we have been only focusing on the safety of ruling out PE on the basis of. And after we stopped doing accuracy study versus pulmonary angiography, we lost track of, making sure that the test was specific enough and that patients that we were diagnosing with PE would actually have a PE or not. And we have consistent data now showing that with the use of multi-detector CT, we are increasing the incidence of the PE and we are detecting PEs that we were not detecting before. And that's a very nice paper showing that in the States, introduction of CTPE was clearly associated with overdiagnosis, very significant decrease in the incidence, but decrease in the case fatality rate. That paper that a lot of people forget as well, randomized trial from Dave Anderson, comparing two algorithms, one based on the CT, the other based on the VQ scan. And what's really striking in that study is that in terms of safety, there was no significant difference. You can use both, and if the strategy is negative, you're happy the patient doesn't have a PE. But you need to be aware that if you use a CT, you will confirm PE in 5% more of patients than when you use VQ. That's more than 1/3 increase in additional patients that you will treat with anticoagulants, while likely, if you wouldn't have known that they had a PE and wouldn't have treated them, everything would have gone very well. So are there false positive findings? Are there non-clinically relevant findings? I won't go back to the subsegmental PE things that was covered by Dr. Carrier at the SSC. Likely it explains part of it, not all of it, but it's not only that. There is an overdiagnosis and we don't know exactly why. So the next thing I want to touch on, and that's perhaps why you don't like the VQ as well, is that there's been such a change on the VQ side as well that it's not always easy to follow that for clinicians. So what we used to get is a planar VQ scan, same thing than in PIOPED. So, dual head cameras, the patient is lying down and you inject these isotopes, so the patient is the emitter, and then you get the images, and then you change the site of the reception to get the oblique views, and you end up having your 6 views allowing PIOPED interpretation of the VQ scan. With the planar, what happened is that same thing as with the spiral CT, right? The detector goes around the patient, and it allows to acquire much more images and to get tomographic images of your patients as well. So you end having whatever you want, transversal, sagittal, coronal views, and that allows a much better depiction of and localization of the perfusion defects, and seeing things, no superimposition of the structure, and seeing things that you wouldn't have seen on a regular planar VQ. So the NUCMED guys, they just love it. They say it's much better, I don't want to use a planar anymore, I get much better resolution with that test. And in all their other indications, they went to SPECT. So when they do a heart scintigraphy, a bone scintigraphy, they just switch without, notifying anybody, right? In pulmonary embolism, we are reluctant to do that or to let that happen because we still lack a good study saying that it would be really accurate, because again, misdiagnosis should really be avoided in these patients. And at the same time, when they did that, when they developed the tomographic approach, they also changed the way they interpret the result. So they got rid of the probabilistic approach and just say there is a PE or there is no PE, which is something we're not really comfortable with. Even initially they did that to please us so that we wouldn't have to think about combination with, clinical probability and so on. So could the SPECT VQ be an alternative to the CT and the planar VQ? It could have improved performance compared with the planar. It would simplify the algorithm, because then you would be in a CT-like algorithm where you would just do a SPECT VQ in patient with high probability or positive D-dimer and just go by the result. But the question that remains as well is what's the risk of overdiagnosis as compared with the CT scan and as compared with because it's much sensitive for sure. And the data we have so far are scarce or low quality evidence on the accuracy for the diagnosis of PE. We don't have a management outcome study. We don't have a randomized trial comparing with other imaging modalities. But that being said, we recently surveyed 331 nuclear medicine centers in Australia, Canada, and France. And what they told us is, we didn't tell you, but we stopped doing planar and we're using SPECT, 72% of centers. So we asked, okay, who is still doing planar? 20%. Among you, who is doing PIOPED? 30 to 40% of them. So eventually, currently, only 10% of your nuclear medicine centers use planar VQ and PIOPED criteria, although we all think that that's what they do all the time. Okay, so I think that's really something we need to tackle as well and to better evaluate. So in summary, major progress in the 2 previous decades, a lot of remaining challenges, fine-tuning, controversies to improve the yield of the non-invasive testing, to tailor the diagnostic strategy for specific subgroup of patients, and for sure we need to be prepared to integrate in our algorithms the new improving technologies, the impact on our diagnostic strategies. I didn't go to MRI, but a lot could be said there as well. Thank you for your attention.